Good morning. It's a pleasure to introduce Joe Hill, who is Professor of Medicine and Molecular Biology and Chief of the Division of Cardiology at the University of Texas, Southwestern Medical School in Dallas, Texas. Joe was born in Burlington, North Carolina, the 19th largest city in North Carolina, with a population of 51,000 at the last census. He grew up on a working farm. His father, who was also a CPA, certified public accountant, planted corn, tobacco, and soybeans, and maintained 100 head of cattle, 20 hogs, and a menagerie of horses, cats, dogs, and peacocks. Joe spent his weekends and summers feeding animals and repairing fences. Cattle instinctively knew when the electricity was down in the electric fences. And when that happened, they broke through, wandered onto the cornfields of neighboring farms, and began feasting. Joe's family would be called at 2 or 3 in the morning in order to chase their cattle back. Joe remembers getting into a pickup truck with his father to wrangle those cattle, those errant cattle. By the time he finished grade school, Joe set his sights away from the farm and toward, instead, the sciences. This led to college at Wake Forest, followed by medical school at Duke, an institution that is not unknown in our cardiovascular division. He graduated in 1987 with an MD, PhD degree. After 4 years or 5 years at the Pasteur Institute in Paris, he was a house officer and cardiology fellow at the Brigham and Women's Hospital. After several years in his first faculty position at the University of Iowa, he joined the faculty at the University of Texas, Southwestern Medical Center in 2002, 17 years ago, as Chief of Cardiology. He has mentored or supervised over 45 postdoctoral fellows and graduate students. In 2016, he became Editor-in-Chief of Circulation. Please join me in welcoming Joe Hill, whose Grand Round talk this morning is titled Renovations in the House of Medicine. Joe Hill.
Somebody's been doing some homework. My father was a hobby farmer, which those two words together never made sense to me. Anyway, those are many, many fond memories. And the Cohens, Larry and Jane Cohen, have been friends for many, many years. And it's my pleasure to speak with you today. I'd like to give you my perspectives a little bit on where medicine, cardiovascular medicine has been, where it is now, and where I think it may be going. Non-communicable diseases have outstripped communicable diseases around the world. This has been true in the West for years now. It's now true in China. As of not so long ago, it's true in India. And before long, it'll be true in Africa. Soon, non-communicable diseases will dominate the face of healthcare around the world. What does that look like? It looks like cardiovascular disease, far and away the #1 killer of men and women in the developed world and in the developing world. For example, here in the West, 1 out of 4 women will die of cardiovascular disease, 1 out of 4. Contrast that with breast cancer, which is 1 out of 40, 40. Many people don't know that, many women don't know, many practitioners don't realize that. As such, cardiovascular disease knows no boundaries. It is a global scourge, one that is evolving over time that I'd like to review with you. Looking back now almost 20 years ago, the World Health Organization said that the number one killer of human beings was high blood pressure. Number two, if you lump tobacco and cholesterol together, that would be atherosclerotic cardiovascular disease. If we jump over malnutrition, which is becoming much, much less of a problem these days, number three is diabetes, metabolic stress and diabetes. I will submit to you that ischemic heart disease is sliding down this list and will be overtaken by cardiometabolic disease with time. This is what it looks like now, age-standardized death rates around the world, and you can see that it is no longer a problem that is relegated exclusively to the developed world. So just for a moment, let me philosophize for a second. We as physicians, of course, every day we see a patient, we try to cure a disease, to eliminate it, to wipe it off their problem list. If you think about it, we can cure a lot of infections and some cancers, but there are really very few cardiovascular diseases that we can cure. We can cure an AV-NRT, we can cure Wolff Parkinson White, but everything else, essentially, we have to settle for the next best thing. With rare exception, we can't cure cardiovascular disease, and so each one of us in this room settles for the next best thing, which is to take an acute disease that has morbidity and mortality associated with it and transform it into a chronic disease that can be managed over time. That is the definition of success for the great majority of what we do. When I went to medical school at Duke back in the 20th century, I sat in a room not unlike this and heard two lectures as a first-year medical student about a syndrome that was emerging in Northern California and in Haiti, where young men were having their immune systems shut down precipitously. They were developing crazy cancers and unusual infections, and they would die. It was called the Acquired Immune Deficiency Syndrome. Nobody had the first idea what the cause was, but it was a death sentence. If you got the Acquired Immune Deficiency Syndrome, you were dead. Now, as of 2017, 50% of people with HIV/AIDS are over 50 years of age. HIV/AIDS has not been cured, but it's been transformed largely into a chronic disease that can be managed over time. How does this pertain to cardiovascular disease? Back in the 1960s, before the advent of the coronary care unit, if you had a heart attack in the hospital with a nurse standing at your side, there was a 30% chance you were not going home. With the advent of the CCU, with defibrillation and hemodynamic monitoring and beta blocker therapy, that was cut in half in about 20 years. By the 1990s, with antiplatelet therapy, thrombolytic therapy, PCI, it was cut in half again. Now, in most hospitals in this country and in Europe, the in-hospital mortality for cardiovascular, for a heart attack, MI, is about 2 or 3%. It's been cut in half and cut in half and cut in half. So in other words, these people who 50, 60 years ago would have died, that acutely lethal disease has been transformed to a large extent to a chronic disease that can be managed over time. In fact, if we take it beyond just MI and look at cardiovascular disease in general, you've seen this before, there's been a dramatic 75% decline in age-adjusted mortality from cardiovascular disease. Huge success, where we are transforming this acutely lethal disorder into a chronic one that can be managed over time. I will point out, however, that these successes, this is heart disease, that's that same curve with cancer, have stalled in recent years. 8 years ago, for about 5 years, it was flat. Now for 3 years, we're backing up. We're actually losing ground for the first time in many, many years. Nobody knows exactly the underlying mechanism, but I would speculate that it likely has something to do with the pandemic of cardiometabolic disease and obesity and diabetes that we will discuss. Now, cardiovascular disease looks different in other parts of the world. This is STEMI rates in China, which I have occasion to go there regularly, as does Harlan. And the atherothrombotic manifestations in the developing world are still quite prevalent. So that's where we have been. Cardiovascular disease is different now in 2019 than it was 20, 30, 40 years ago. Where do we think it's going to be going? Sadly, a lot of it is determined by these behavior patterns as illustrated here. This is obesity, BMI greater than 30 in the United States, and where obesity is, diabetes is. the face of our nation has changed in the last 20, 30 years with this enormous expansion of cardiometabolic stress, obesity, and diabetes. And again, sadly, this is where I think our species is going. And as you heard, I'm not a native Texan, but I can tell you in Texas, we definitely have this going. So this is obesity in men and women between 1980 and 2008. And you can see that it is a pandemic around the world. In the United States, where is North America right here? This is what obesity looks like in America. With this amount of obesity, we have a prevalence of diabetes somewhere in the range of 14%, 1-4. In East Asia, in China, this is what obesity looks like. That little bit right there. The prevalence of diabetes in China is 14%, the very same number. It's estimated that in China, a country of 1.4 billion people, 40% of them have pre-diabetes, which, to simplify, as you all know, pre-diabetes typically becomes diabetes. 20 years later, you get cardiovascular disease, and you typically succumb to it. So there is a tsunami of cardiometabolic disease emerging around the world. Why it is that in East Asia, it only takes this much obesity to trigger the same cardiometabolic stress as it does in the West is unknown. There is a theory that is actually the same in South Asia, in India, that there is a thrifty gene. This is all total speculation, that in these societies that evolved in the setting of caloric restriction, caloric deprivation, there is a tendency to retain adipose tissue in a visceral distribution, which is toxic. And so as a result, it only takes a little bit of excess weight to trigger the cardiometabolic stress that's seen in the East. That is a theory. Hundreds of millions of people now are faced with diabetes around the world. As you can see here, this illustrates this dramatic expansion. Coupled with this, you'll see where I'm going with this in a second, is a global pandemic of hypertension. I was standing at a CCU in China a couple of years ago, and I turned to a cardiologist from China. I said, "How much does lisinopril cost a day of lisinopril in China?" He said, $2 a day. And I turned to my colleague from Germany, and he said, "No, in Germany it's a nickel a day, just like in the U.S." I'm digressing, but I ended up finding an economist at Johns Hopkins who studies this, and he said, "Yeah, Dr. Hill, everybody knows that." And I said, "Well, the cardiovascular community doesn't." And so he did a little study that we commissioned for Circulation, where he took the 5 most prescribed antihypertensives in China. They were amlodipine, lisinopril, I can't remember the others, and compared the cheapest price he could find in China versus the highest price for those same drugs he could find in the US, adjusted it for gross domestic product, and the ratio was 1.5 to 6.5x higher in China, where there are hundreds of millions of people with diabetes, with hypertension. And I will tell you that the government picked up on this. It turns out the underlying mechanisms are complex. You get your meds, there's no CVS on the corner, you get your meds from the hospital. The hospitals are underfunded, so they raise prices on medications and so forth. But the government is addressing this. So here's an interesting study. This was in The Lancet some months ago. This is the probability of dying before the age of 80 for women. Okay, remember this is a non-communicable death from non-communicable diseases for women before the age of 80. And this graph is every single country in the world. There's India, where the likelihood that a woman will die before the age of 80 of a non-communicable disease is nearly 50%. They are making some progress, but they're not on target to achieve the 30% by 2030 goal that the World Health Organization has set. China is around 43%, a little bit better, but also not, having some success. We are 10 points further down here, but we are stagnant. We are not making any progress. The winners are Japan, South Korea, and so forth. The countries that are doing the least well are Afghanistan, Yemen, and Africa. How does this pertain to men? Everything is about 10 points higher. The likelihood that a man will die of a non-communicable disease before the age of 80 is over 50% in India. They're making some progress, but not fast enough. China, it's right around 50. The US is down here at 42, but again, we're stagnant. The winners, again, are Japan, Iceland, Australia, and Switzerland. And the countries that are doing the worst are up here. What are these non-communicable diseases that I'm talking about? They are cardiovascular disease. The diseases that we in this room battle every day. So where is the future going? My friend and mentor, Eugene Braunwald, said to me a few years ago, the thrombocardiologist of the 20th century will be replaced by the diabetocardiologist of the 21st century. And I think he's exactly right. In a cohort of 500,000 people with diabetes, 27% of them have heart failure. And what kind of heart failure is that? Heart failure with preserved ejection fraction. You're all aware that heart failure bends out in two different categories, that with a reduced ejection fraction less than 50%, and that which is preserved above 50%. This so-called HFpEF accounts for a huge toll on individuals and society and healthcare expenditures. It has the same morbidity and mortality characteristics as HFrEF, again, it is a global issue. Importantly, it is a systemic disorder. It is the cardiovascular manifestations of a systemic disorder that affects the kidneys and the lungs and skeletal muscle and so forth. There is a predilection for females, a 2-to-1 predilection for females to develop HFpEF. We'll talk about that more later. And there are only two types of heart disease that are going up in this world, AFib and HFpEF. HFpEF is going up. HFrEF, thankfully, is going down, but HFpEF, the prevalence is increasing around the world. When we treat our patients with HFrEF, we have a range of therapies to treat them, ARBs, ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, and so forth. Every single one of these things that we use every single day in our HFrEF patients has failed in HFpEF. There has never been a positive clinical trial in HFpEF. Never. Even though the mortality and morbidity characteristics are very similar to HFrEF. It's just as bad to have HFpEF as it is to have HFrEF. In other words, our toolbox for HFrEF is replete with many different drugs, including some new ones, angiotensin receptor neprilysin inhibitors, resynchronization therapy, mechanical circulatory support. We have a tool chest of many things to do for our HFrEF patients. We have nothing for HFpEF. We diurese them, we treat their diabetes, we treat their hypertension, and we're frustrated. Indeed, it has been said that HFpEF is the single greatest unmet need in cardiovascular medicine. Now, that's not for want of trying. People have been targeting HFpEF for many years. And I will submit to you that in my view, one of the major failings here has been in the preclinical space, where the literature is polluted with models of HFpEF in animals that simply do not recapitulate the realities we see in our patients. There are a lot of them. That you see the word HFpEF in the title, and I can assure you, if you look into that, you as a care provider will recognize that this is not the HFpEF that you see in your patients. And I believe that has led to many, many, many dead ends, ultimately clinical trials that have ultimately failed. So about 4 years ago, we decided to tackle this. Was fortunate to recruit a cardiologist postdoc to the lab from Italy named Gabriella Schiattarella. And we decided, we're going to take this on. We're going to try to develop a HFpEF. We were so disgusted with the models in the literature, we decided to develop our own. So we decided to make a mouse that looks like a HFpEF patient. Most patients with HFpEF are obese with diabetes and they have high blood pressure. So we made a mouse that's obese with diabetes and has high blood pressure. In so doing, we formulated a 2-hit hypothesis that mechanical stress, hypertension, coupled with metabolic stress, this 2-hit mechanism we hypothesized would lead to HFpEF. I will remind you that there are hundreds of millions of people on this planet today with metabolic stress, obesity and diabetes, and concomitant hypertension. So that was our hypothesis. We arbitrarily raised blood pressure 40 points using a compound called L-name, which inhibits constitutive NO synthases. And we exposed the animals to a high-fat diet, thereby making them obese with metabolic stress and diabetes. And again, our hypothesis was that HFpEF would be the end result. So in subsequent slides, you'll see 4 treatment groups. You'll see animals that were exposed to just normal chow, no hits at all. 1 hit, the metabolic hit. The other one, hypertensive hit, and then others, a fourth group that has both hits together. One hit alone, the other hit alone, or the two hits together. And we will take these animals out and we will phenotype them extensively. And I will tell you that we held ourselves to the standard that HFpEF that we see in patients is heart failure, elevated filling pressures, pulmonary congestion, a preserved ejection fraction, diastolic dysfunction, unequivocal systolic contractile dysfunction if you measure it using strain measures, much more sensitive than with an EF, microvascular dysfunction, capillary rarefaction, modest fibrosis. We had a laundry list of about a dozen things that we would not be satisfied that this was similar to human HFpEF unless we saw all those. Now, sometimes it only takes one hit. For example, high-fat diet alone, irrespective of L-name, is sufficient to render the animals obese and glucose intolerant. No surprise. Conversely, L-name alone, irrespective of high-fat diet, is sufficient to raise systolic and diastolic blood pressure. No surprise. Here are our 4 treatment groups. You can see that the ejection fraction is preserved across the board. However, if you look at contractile function using a more sensitive measure, global longitudinal strain, you can see that it is suppressed uniquely in the animals exposed to 2 hits, just like we see in our patients. Evidence of diastolic dysfunction and elevated filling pressures, both non-invasively and invasively, again, uniquely in the animals exposed to 2 hits. Modest hypertrophy, and importantly, exercise intolerance and pulmonary edema, again, uniquely in the animals exposed to 2 hits. These animals have bona fide heart failure. Again, modest hypertrophy, modest fibrosis, just as HFpEF is much less fibrotic than HFrEF in people, as in here. Coronary flow reserve down the LAD in a mouse is abnormal in these animals, and there's modest capillary rarefaction, again, as we see in patients. If we isolate the myocytes and put them in a dish, we see these contractile abnormalities are retained within the myocytes themselves. And very importantly, here's a key point, HFpEF in people doesn't become HFrEF. The preclinical literature is full of temporary HFpEF, which makes no sense. That makes no sense. We've taken these animals out now for 2 years on these 2 stresses, and these animals still retain HFpEF. They do not become HFrEF. So after a year of working on this and throwing stones at this model, we decided that these animals had the comorbidities that we see in our patients. They had the contractile abnormalities that we see in our patients. They have bona fide heart failure, and they have the molecular and cellular abnormalities that we see in our patients. And so at that point, now 3 years ago, we planted a flag and said, this we believe is the most informative HFpEF model that we have seen in the literature. And then we turned our attention to underlying mechanisms. Let me introduce you to something called the unfolded protein response. I'm sure many of you are familiar with this. When a cell gets sick, it can't process proteins normally, and those proteins don't fold normally. They aren't transited to where they need to be. They fall out of solution, and it's a very toxic thing that will kill the cell. So all of our cells, all eukaryotic cells, have an elaborate response, so-called ER stress response, unfolded protein response, to target that, to eliminate these proteins that are unfolded in the endoplasmic reticulum. It's actually quite beautiful biology. Think about it. If there are too many unfolded proteins, the cell will stop making protein. It will degrade the proteins in the ER. It will degrade the proteins in the cytoplasm. It will elicit more chaperones to try to fold those proteins and to chaperone them where they need to be. And if all of that fails, it will kill the cell. It will commit suicide. This biology is conserved all the way back to yeast. There are 3 arms of the unfolded protein response, and I will just emphasize for today's talk, this middle one. This is the only pathway that exists in yeast, this one arm of the unfolded protein response, where when an unfolded protein interacts with this protein called BIP, it pulls it off, activating this guy, IRE1 alpha, which is an endonuclease that cleaves mRNA. It encounters the transcript coding for XBP1 and splices it, and you get XBP1 spliced, which is a transcription factor that elicits an inflammatory response. An enzyme that clips this RNA, activating this transcription factor, and leads to activation of a number of genes. We have studied this pathway before. We published a paper a few years ago where we found that this pathway is activated in the setting of myocardial infarction. And what we found in this study that we reported is that transcription factor actually goes over and activates something called the hexosamine biosynthetic pathway by targeting four genes, leading to upregulation of O-glycinylation of many proteins, which is cardioprotective. So this postdoc here was able to link the huge biology of the unfolded protein response and the hexosamine biosynthetic pathway and pull them together for the first time and reported that it elicits this cardioprotective response. So in fact, we have looked at this pathway in a variety of different heart diseases. It's activated in myocardial infarction. It's activated in hypertension. It's activated in diabetes. It's activated in every form of heart disease we've ever looked at until here. For the first time, the unfolded protein response is suppressed in HFpEF. This has never been reported before in any form of heart disease. You can see high-fat diet turns it on, L-name turns it on, but when they are concomitant, measured multiple different ways, it's turned off. Extremely surprising finding. If we isolate adult mouse ventricular myocytes, we find the same thing. If we look for the activity of our friend here, this enzyme I told you about, it is down-regulated. Never been reported before. So I got on the phone with my friend David Cass at Johns Hopkins, where they routinely biopsy patients with HFpEF and HFrEF. And I said, David, can you do me a favor? Can you tell me what XBP1S levels are doing in human beings with HFpEF? He found that it's selectively downregulated in HFpEF and not in HFrEF. So that was the first reality check that these very surprising findings that we were uncovering pertain to the human case. So we carried on. There's too little XBP1S. What happens if we put it back? We engineered a transgenic animal. If this doesn't make sense to you, suffice it to say that we are expressing XBP1S exclusively in cardiac myocytes, only the cardiac myocytes, in a way that we can control it by the presence of doxycycline in the water, in the drinking water. When there's doxycycline present, nothing happens. The transgene is not turned on. However, when we remove the doxycycline, we can turn it on and we can restore the levels of XBP1S in the cardiac myocyte. So we took these animals, we gave them HFpEF, and then we stopped the doxycycline, and for the next 2 weeks, we restored XBP1S levels to see what would happen. The animals, their diastolic dysfunction improved, despite the fact that these metabolic and hypertensive stresses persist. Their pulmonary congestion resolved. They started running again. It's amazing. Just restoring XBP1S to those cardiac myocytes for 2 weeks was able to antagonize this response. So why is there too little XBP1S? What's the problem there? We don't know. We know quite little about mechanisms of HFpEF, but one of the things that we know is that obese tissue is inflamed. Obese individuals have a chronic systemic inflammatory response that nowadays we call meta-inflammation, metabolic inflammation. And one of the hallmarks of that is inducible NO synthase. NO synthase is one of the hallmarks these days of this new concept called meta-inflammation. So actually we found a paper in the literature, this is not our work, where people were studying obese liver, and they found the same thing. They found that XBP1S was down-regulated. INOS is through the roof. INOS is up-regulated tenfold, leading to the generation of so much NO, so much nitric oxide, that it is covalently coupling itself to many, many, many different proteins, crippling them, including our friend IRE1 alpha. These investigators have posited a mechanism that NO, this surfeit of NO, is covalently coupling to and crippling IRE1 alpha, preventing it from doing its endonuclease activity and preventing the expression of XBP1S. So we looked for that in our animals. We looked in our animals and we found that sure enough, INOS is upregulated 6 or 7-fold. Now I'll remind you that one of the paradigms in HFpEF is that there's too little eNOS. That's why people have treated these patients in trials with sildenafil and isosorbide and nitroglycerin, trying to restore that. In fact, what we find is just the opposite. there is a huge oversupply of INOS. I'll also remind you that INOS makes 1,000 times more NO than eNOS does, 1,000 times more. So here, when we isolate adult mouse myocytes, we see the same thing. We see this smear of proteins that are S-nitrosylated throughout, including our friend IRU1 alpha. So then I got on the phone with my friend David Cass and said, David, please, what is INOS doing in human beings with HFpEF? He wrote back and said it's upregulated 5 to 6-fold. INOS is up in human beings with HFpEF, and in fact, IRE1 alpha is S-nitrosylated and crippled, again in human beings with HFpEF. So to try to put this together in a mechanistic connection, we engineered a virus that makes INOS. We've made plenty of virus. We can make plenty of INOS. We can make plenty of NO. It works just fine. If we take this virus expressing INOS and put it on cells in culture, you can see that initially XBP1S goes up, up, up as a stress response, but once there's enough NO to cripple IRE1 alpha, it's downregulated below baseline. What happens if we target this in our animals? We gave animals HFpEF, and then we exposed them selectively to an INOS inhibitor. Now, I told you we used L-name to inhibit constitutive NO synthases. L-name doesn't touch INOS by a factor of about a 20-fold, and furthermore, since it goes up another 5-fold, L-name doesn't touch it, so we used a different compound that selectively targets INOS. So we gave these animals HFpEF, and we found that in the ones that were exposed to this inhibitor, diastolic dysfunction improved after they developed the syndrome. They started to run again, and also I don't have a slide to show it, but the pulmonary congestion resolved. Also, I don't show it here, but if we selectively inactivate the gene coding for INOS, we can either prevent the development of HFpEF, or if we let them develop HFpEF and then knock it out, then we can make the HFpEF turn around and go get better. So we reported this a few months ago, this model where the concomitant stress, again, that millions of human beings face of high blood pressure coupled with obesity and diabetes leads to HFpEF. That leads to a dramatic upregulation of INOS, a suppression of this enzyme, and a decrease in the presence of this important transcription factor. Again, as I alluded to earlier, I think this provides a biological explanation for the failure of many of the clinical trials that have actually tried to increase NO levels. In fact, if you look at those trials, the subjects that got sildenafil or isosorbide, not only did they not get better, they actually got worse. And now we understand why. I think now we understand why. In data we haven't yet published, we've actually figured out what happens further downstream. I can go into this in detail later. It turns out that XBP1S targets a famous transcription factor called FOXO1, which is ubiquitinated, and this leads to a steatotic response in the myocytes. I can discuss that with you further if you'd like later. So, 3 little teaser tales here. Why the preponderance of HFpEF in females? We have a paper in Press at Circulation where we exposed male and female animals to these stresses. Our hypothesis was that the female mice would be predisposed to worse HFpEF than the men. There's a 2-to-1 predilection in people. If we expose these animals, male and female, you can see they develop the same amount of obesity, high blood pressure, and glucose intolerance. They are exposed to similar metabolic stress. However, the female mice develop less LVH, less diastolic dysfunction. The females have a reduced exercise capacity, but less pulmonary congestion. If we take the animals out to 15 weeks, the males continue to get worse, whereas the females do not. Bottom line is that in these female animals, they are relatively protected from HFpEF, by the way, like virtually every other cardiovascular disease that we know. So we reported that in the literature, and if we over-reactomize the animals to try to probe the role of sex hormones, there was no effect. So our hypothesis is that the female predilection for HFpEF is not a biological mechanism, but I hypothesize it's a demographic one. Everyone in the room knows that women have a higher EF than men, and I believe that the arbitrary cutoff of 50 that we use is silly. It's oversimplified. It probably should be a higher number for women who start off with a higher EF, that maybe for a woman whose EF drops to 55, We would call that preserved, but in fact it's reduced. That is a hypothesis. So those data are in press now. Now, 80% of people with HFpEF will develop atrial fibrillation. And these two disorders track together and they each make the other worse. So we asked the question, do these animals develop atrial fibrillation? And they do. You have to induce it in mice. Mice don't develop spontaneous AFib, but the animals with HFpEF do in fact have a predilection for atrial fibrillation. Interestingly, it's a different mechanism than what we see in HFrEF, where there is no atrial hypertrophy, there's no atrial stress, there's no atrial fibrosis. Very surprising. In fact, what we find, and this is where Larry Young's a world's expert here, is that there's impaired AMP kinase signaling here, where the electrotonic coupling of atriomyocytes is perturbed. The gap junctions aren't sending electrical signals properly between the myocytes. It's not a stretch problem, it's not a fibrosis problem, but rather it's an electrotonic coupling issue. What happens if we target that? Everyone knows that we can target AMP kinase using our friend metformin. What happens if we do that? The animals, their atrial fibrillation gets better with metformin. That has not been published yet. Finally, I'll tell you a story that we're working on now. The metabolic stress in these animals. If you think about it, if you take an animal and you expose it to high blood pressure, it will move toward using more glucose. If you expose it to diabetes, the myocytes will start to use more fatty acids. So these poor myocytes are being pulled in two different directions. They don't know which way to go. They're being told to use more glucose and to use more fatty acids at the same time. As a result, the mitochondria are unhappy and structurally deformed. And to simplify a great deal of work, if we take the mitochondrion and we try to dissect the underlying mechanisms of metabolic perturbation here, what we find is the TCA cycle is perfectly normal. The electron transport chain is normal, but we find two defects, one in PDH, pyruvate dehydrogenase, that involves the flux of pyruvate into the TCA cycle, and we find two enzymes here which are hyperacetylated within the fatty acid oxidation pathway. So I won't show you all the data, but again, what happens is the pressure stress and the metabolic stress leads to a downregulation of an enzyme called SIRT3, which is a deacetylase in the mitochondrion. Downregulation of SIRT3 and downregulation of its required cofactor, two key proteins are hyperacetylated, and if we restore that NAD by either using a pharmaceutical agent or activating the enzyme that codes for its biosynthesis, the HFpEF gets remarkably better. It's amazing. The metabolic flux within these animals is restored and the HFpEF improves. So back to the drawing board. Where are things going in the future? You're all aware that the heart is remarkably plastic. It can grow and shrink in a remarkably plastic way, about a 100% dynamic range from growth to shrinkage. The heart grows under conditions of physiological stress. I used to call this the Lance Armstrong heart until we realized it was much more multifactorial, that whole problem issue. This type of hypertrophy is purely good for you. There's one pathway that does it. There are about a half a dozen pathways that lead to pathological growth of the heart, and this is purely bad for you. If these stresses are persistent, this thick-walled ventricle becomes thin-walled, the narrowed chamber becomes dilated, and heart failure ensues. For sake of completeness, I'll remind you that the heart can shrink. The heart can shrink under conditions of unloading, like bed rest or weightlessness, or mechanical support, or catabolic conditions like cancer. The heart, for a patient in bed rest, the heart shrinks 1% per week in bed. The heart shrinks 1% per week in outer space. So if you're going to send somebody to Mars and back for a couple of years, they're going to come back with an atrophied heart. Some of you may remember back in the days of the Apollo moonshots when the astronauts couldn't stand up. They had to be carried out of the capsule, partly because they'd lost a lot of volume, but partly they had an atrophy response. So that's why they trigger physiological growth on the International Space Station to try to target that. What sport triggers the most good hypertrophy? Crew, rowing. So it's both isotonic and isometric, so they have a crew machine up there. So I hope I've convinced you that the face of cardiovascular disease is evolving. It was different 50 years ago than it is today. It will be different again 20, 30, 50 years from now. It's an incredibly dynamic problem. As soon as we solve one problem, another one pops up. At the same time, there have never been more exciting opportunities. This is the best time ever to be involved in cardiovascular medicine. The tools at our disposal are absolutely unprecedented. All of you are aware of CRISPR-Cas9 technology, where we can edit a gene. It's now become routine in all of our laboratories to edit a gene, to make changes, eliminate or add genes. The day will come before long, I submit, where this will be in the clinical space. Arguably in Duchenne muscular dystrophy, maybe one of the very first areas, but in other areas, we will be doing this with human beings in the next number of years. I'll also submit that in the next 20 years, we will see the emergence of xenotransplantation, where we will be transplanting pig hearts and pig livers and pig kidneys. People are busily right now editing the genome of the swine to eliminate the retroviruses that are harbored in there, and to humanize the genome, such that we will be, I believe in the next 20 years, we will see this emerge as an important therapy. Inflammation has been sort of a theoretical thing in heart disease now for many years. It's sort of been lurking in the back of all these different diseases as a theoretical concept. That all changed 2 years ago when Paul Ridker published the CANTOS trial, targeting a laser strike on a single pathway, interleukin-1 beta, finding a significant mortality benefit in heart disease, and by the way, and also in lung cancer. Now this has spread, the meta-inflammation that I just reported in HFpEF, another example where we're targeting a specific pathway in inflammation. I personally believe that the notion that you sort of dumb down inflammation, use like steroids or methotrexate, that has consistently failed. But there is promise for going after a surgical strike at different particular parts of that pathway, and we've seen that now 2 or 3 times in the last couple of years. Precision diagnostics, you're all aware that we can take a cell, we can take a fibroblast or a white blood cell from a patient and induce pluripotent stem cells, and then turn them into myocytes or whatever cell we want, so that we can study Mrs. Jones's heart cells and Mr. Smith's heart cells in a dish, moving sort of to the point where we will make our therapies more precise. Rather than treating populations, we'll treat individuals. We can do drug screening in a dish. This is certainly prime time already. Many different devices that I believe there's a fair amount of hype around this, but I do think with time we will see that these devices will provide information that's useful. Blockchain technology, some have said that the blockchain, which is a distributed, encrypted way in which information is shared around the planet, will be as transformative as the internet, some people say, such that you can walk into a patient's home and pull down everything, their medical record, interface with it, and return it as one of many examples. Machine learning, we're starting to see more of this, where machine learning is teaching us things that we as humans can't see, helping us read our mammograms and our EKGs and our chest x-rays. And there's a company that I've heard about that is working on an echo machine where you, with no training whatsoever in echosonography, you can put a probe on a chest and it will say, slide it over 1 centimeter, tilt it up 10 more degrees, and then it'll collect the image that it wants, the image that we're all used to seeing, and provide you with at least a preliminary interpretation of that, thereby democratizing echocardiography. You no longer need to be a trained sonographer when this technology arrives. Big data, of course, are here to stay. Again, I've said this already, where we're moving toward treating individuals rather than populations. Cardiac regeneration is a field that's been very, very controversial, very, frankly, marred by wrong malfeasance in the realm of cardiovascular science. But I do believe that there is promise. I think there's essentially no hope for cell therapy where you inject cells into the heart, and I think that's not going to go anywhere in my view. But I do believe that with time, we will be able to take a cardiac myocyte and for example, identify neighboring fibroblasts and tell them to turn into a cardiac myocyte. There's technology in the preclinical space and starting to in the clinical space that I believe that with time this will happen. I also believe that with time we will be able to tell a cardiac myocyte to return into the cell cycle and to start to regenerate again. I think both of those, I believe, have real promise going forward. The senescence program, the biology of senescence, is really exciting, and I think that we will see some promise there. Finally, one of the big black boxes in this world is the microbiome, about which we understand very, very little, but unequivocally has an effect on cardiovascular medicine. We had a paper in Circulation where people took mice and they gave them a heart attack and had this much injury. They took another cohort and they sterilized their gut, and the heart attack got worse. Then they took those same animals, sterilized their gut, and then restored the microbiome, and it changed. Somehow, the response to myocardial infarction is informed by the gut microbiome. Mechanism unknown. So again, we have unprecedented opportunities and unprecedented challenges facing us. There's never been a more exciting time to be in our field. The last thing I will say is one of the major challenges that we face is bending the cost curve of healthcare. We in this room are bankrupting Medicare. 43% of Medicare is cardiovascular, and this is becoming a global problem. The solution to this problem is at the level of research, I believe. We will always continue to take care of our patients, but the way in which we are going to bend that cost curve is trying to understand these mechanisms and address these mechanisms, implement these therapies going forward. So with that, I will stop. This is my amazing team. This is Gabriela Schiattarella, the postdoc who did the HFpEF work. This is Amanda Dan Tong, who did the female stuff, the AFib work, and the mitochondria work. And this is Tom Gillette, my partner in crime for a long time. So thank you for your attention. With that, I will stop.